Thank you very much for joining us again today. In today's webinar, we're going to focus, of course, as we know, on the patient's journey, which is mostly what we're dealing with in this surgical webinar. We know that our patient needs to be prepared for surgery, has to go anesthesia, needs to be positioned and prepared and draped. We need to get all of our equipment ready for our surgery. We do the surgery and hopefully our patient leaves the theatre well and good and recovers perfectly. As we explained last week, 2 weeks ago in our first webinar, that there are 5 webinars in this particular series. In webinar 1, we covered preparing for surgery and developing bad habits and how those bad habits can lead to contamination or potential contamination for our patients in the surgical environment. In webinars 3, 4, and 5, we'll look more into risk like fire safety, sharps management, specimen errors, retained surgical instruments, patient positioning and staff injuries, ergonomics around that, managing surgical tables, managing surgical lights, and those kind of things. Today, however, we have the pleasure of our guest joining us, and our guest presenter is going to be Briette du Toit. Briette du Toit heads up the Infection Prevention Department at Mediclinic. Briette has years of experience as an infection prevention specialist, and we are very grateful for having her join us today.
Okay, so today we're going to talk about the monitoring of the operating room environment, and we are going to look at a few aspects that needs monitoring. The first thing is the temperature in the operating room, the relative humidity, ventilation, hand hygiene, and then environmental cleaning. So we're going to look at those few aspects. Obviously, there are much more, but we are going to focus on those that I mentioned. So first of all, if we look at what is monitoring, we see that it is the regular observation and recording of activities, and it is a process that helps improve performance. And why should we monitor, or why should we do regular checks? And first of all, it is to continuous monitoring can detect underlying problems before they have an adverse effect, and to identify trends and to provide an opportunity for improvement of processes. It doesn't help that we monitor and that we identify problems and that we do not really do something about it. So it is important that we implement some improvement processes or continuous improvement processes. So why do we need to monitor the environment? First of all, there are regulatory requirements by the Department of Health, Regulation 158 and 187, the National Building Regulation, ISO, IUSS guidelines, the Occupational Health and Safety Assessment Series, accreditation for CUSASA if you are part of that accreditation body, and then the Office of Healthcare Standards Compliance. That's the one reason to comply to regulatory requirements. And then the other reason is that because it's part of good clinical practices. And when we talk about monitoring there, it is specifically hand hygiene, environmental cleaning, and then compliance to IPC bundles, surgical site bundle, CLAPSI, CAUTI. Those are the 3 main ones that's relevant to the operating room. So what do we monitor in theatre and CSSDs? It's usually the temperature, humidity, ventilation and the particle counts, water quality, the autoclaves, washer disinfectors. We look at the parameters of the washer disinfectors, and with autoclaves, on a daily basis, we will do a biological test and a chemical test. Then disinfectants, we need to look at the how it is reconstituted and whether it is still whether it is or correctly mixed and reconstituted. Then we look at hand hygiene monitoring and then environmental cleaning. So if we look at specifically the prevention of surgical site infections and what impact their environment have on or has on the development of surgical site infections, we see that there are a number of opportunities where infection can be acquired. First of all, during the perioperative phase, and usually that is where we will specifically look at the adherence to the surgical site bundle and the preparation of the patient, whether he or she took a preoperative shower with chlorhexidine, the way that the hair is removed if it is necessary, clipping versus shaving, and as you all know, we recommend that no shavings should take place and preferably no hair removal. So those are the factors that have an impact during the perioperative phase. Then if there's the intraoperative phase, where we will stand still a little bit later, and then the immediately post-operative phase, where we look at wound care, hand hygiene, personal hygiene, environmental cleaning, those aspects that plays a role. For today's session, we will talk a little bit about the intraoperative phase, which is a huge contributor to surgical site infections potentially. There again, the temperature in theatre plays a big role, and we will talk about that, humidity, the ventilation, the type of procedure, and the duration of surgery. The longer the surgery, the bigger the chance of development of a surgical site infection. Environmental cleaning, hand hygiene, the decontamination of the instruments, and the role that the staff. So if we look at the theatre temperature and what is the impact and what the impact is on surgical site infections, the important thing is the hypothermia, or we want to prevent hypothermia in surgical patients. So the average temperature in an active theatre should range between 20 to 23 degrees Celsius. We need to maintain a core body temperature in the patient of above 36 degrees Celsius, and the relative humidity should be around 55%. There are a number of guidelines where they detail these parameters specifically related to temperature. One is the WHO Surgical Prevention of Surgical Site Infections, which was also referenced by Xana a week or two ago. Then there are guidelines of ITSA, the Royal College of Physicians in Ireland, Health Protection Scotland, American Association of Advanced Medicine, and then the South African Society of Anesthesia, which is a local guideline, and then also the American Association of Perioperative Registered Nurses. So they all reference the temperature that we need to, or the average temperature in theatre. So there are a number of ways that body temperature is lost in theatre. They say that about 60% of heat loss during surgery takes place through radiation, where heat from the core body tissue is transported in blood to subcutaneous vessels and it's lost to the environment through radiation. Then about 22% is lost due to evaporation, where water evaporates from the body even if we are not sweating. Convection is moving of warm air away from the skin through currents. And then conduction, which is the loss of kinetic energy from molecular motion in skin tissue to the surrounding air, and heat is lost when the body is warmer than the environment. So you see that if the theatre is going to be cold, we are going to lose temperature, or the body is going to lose temperature. So practical examples of heat loss in theatre is when we pour cold antiseptics during skin preparation on the patient, exposed body cavities, chest cavities open for extended periods, exposed to cold temperatures and fluid, and the infusion of cold fluids and blood. So all of that is contributing to a lower core temperature. And what is the impact of hypothermia? Even mild hypothermia increases blood loss by about 16%. Delayed wound healing. Hypothermia leads to post-operative shivering and increased oxygen redistribution. Preventing hypothermia increases the risk of other complications, including cardiac arrest. So what happens when the temperature in theatre is too high? We get something like we call raining in the theatre, and this is caused. The high temperatures leads to a build-up of humidity in the theatre. Then condensation can collect on the surfaces, including the room ceiling and equipment. That can then lead to corrosion of equipment if it is moist in the theatre environment, rust and mold growing in the ventilation ducts. Droplets can also potentially fall into the sterile field, and surgical instruments can become contaminated. Open wounds, imagine if these contaminated droplets fall into the open body cavities, and it is extremely uncomfortable to work in. Then, when we get to the relative humidity, the control and management of air humidification in healthcare settings is needed to reduce the risk of contagions, ensure the comfort of healthcare workers, patients, and visitors. And when the relative humidity is too low, we get electrostatic discharges, and that can lead to fire, representing a risk to patients and damages expensive equipment, medical equipment. The relative humidity should be around 30 to 60%, and relative humidity refers to the amount of water in the environment or in the air compared to how much there could be at any given temperature. And typically, more water vapor is present in the air at higher temperatures than there would be in cooler temperatures. So, what is the relation between humidity and pathogens? First of all, at the relative humidity of 30 to 60 degrees Celsius and 30 to 60% and 21 degrees Celsius, influenza viruses is least likely to survive. Bacteria, you get a decreased growth rate at less than 25% relative humidity, but a higher growth rate at 90% relative humidity. Mold reproduce at a rapid rate above 60% relative humidity, and 30 to 50% relative humidity is ideal to control and reduce mold growth. So you see that is the average percentage relative humidity where we have the least growth of molds and bacteria and viruses. When the relative humidity is too high, it results in damp and moist accumulation, encouraging the growth of microorganisms, especially fungi like aspergillus. And if we look at what is the impact of that, this is just a few snippets from outbreaks in various parts in the world due to an outbreak of aspergillus in the operating room, where a number of people had been affected and they got aspergillosis. You can see the lungs of somebody with aspergillus infection. So a low humidity, on the other hand, results in excessive dust-carrying bacteria, electrostatic discharges, and the electric field strength increases as the relative humidity decreases, which then results in a fire risk. If we look at ventilation, proper mechanical ventilation is necessary to prevent surgical site contamination from unfiltered air drawn into the operating theatre, to dilute and remove microorganisms shed in the skin scale. So first of all, we need ventilation to clean the air in the theatre and to dilute the air, and also to prevent contamination. So the air quality in theatre is important to prevent contamination of the environment. Ventilation systems must be functional and maintained. Air should be filtered through HEPA, high efficiency particulate air filters, and the positive pressure inside the theatre with pressure differentials of 10 Pascal between the theatre and the passage. It is important that that we have positive pressure in the operating room, meaning that the air flows from um, from there to the surrounding area and not into the OR, because we want to prevent contamination. So what are the factors impacting on ventilation? The amount of people in the theatre and the movement in theatre. And I'm actually not going to spend too much time on this because Xana did address that in the previous webinar. She spoke extensively about the impact, that study that was done in Ghana, what the impact was of excessive people in the operating room. And what they found was that in that study that only 17% of the visits to the OR was actually necessary. The others were all unnecessary, or most of it, 77% were unnecessary. So that amount of people in and out of theatre, the doors opening and closing, interfering with the airflow and ventilation. And they did a similar study in Johns Hopkins where they looked at how many times the theatre doors open. And during that study, they found that it opened on an average every 2.5 minutes. And every time you open the doors, it interferes. It compromises the positive pressure system, allowing air from surrounding corridors to flow inside the theatre, which is actually not clean or filtered air and can potentially contaminate the area. Then, if we come to hand hygiene. So hand hygiene is the cornerstone of IPC and remains the most important intervention to reduce HIIs. When optimally performed, hand hygiene reduces HIIs and the spread of antimicrobial resistance. There are a number of published studies that demonstrate the important role that HII plays in the prevention of, that hand hygiene plays in the prevention of the transmission of pathogens. So if we look at the reasons why we perform hand hygiene, first of all, it is to interrupt and then to prevent. So we want to interrupt the transmission of microorganisms via the hands between the environment and patients, then between patients and the environment, and to a critical site with an infectious risk, and from blood and body fluids. And we want to prevent colonization and the infection of patients and healthcare workers, and also the transmission of pathogens in the environment. In a study that was done by Garrett and colleagues, they found that an estimated 20 to 40% of HIIs result from transmission by a healthcare worker after touching either another patient or the environment. And they also found that healthcare workers can contaminate their hands with 100 to 1,000 coliform units of Klebsiella species during clean activities, such as lifting a patient or recording of a pulse or taking a blood pressure or just touching a patient. Fingers of nurses are the most likely area to become contaminated, mostly by gram-negative bacilli and Staph aureus. And then there's increasing evidence about the role of the environmental services in the transmission of pathogens. That was also one of the reasons why they changed the WHO hand hygiene procedure to first start with the fingertips while you still have a lot of alcohol and you can adequately contaminate the fingertips. So that was one of, because the fingertips is the part of the hands that are, which touches people the most. If you're for a good resource about hand hygiene, you can definitely look at the WHO documents, the guidelines on hand hygiene in healthcare, and this hand hygiene technical reference manual is a wonderful document to use. There are also audit tools, training material, posters, and very good resources on the WHO website. Then there are a few very important concepts that we need to look at when we are talking about hand hygiene. First of all, the patient zone, and then the healthcare area. The patient zone is that critical zone where we are in direct contact with the patient, and whenever we enter the patient zone, we need to perform hand hygiene according to the 5 moments of hand hygiene. So the patient zone refers to, or it includes the patient and some surfaces and items that are temporarily and exclusively dedicated to them. Personal belongings, the patient's body, gown or clothes, curtains between beds, bed rails, the bedside table, bed linen, infusion pumps, and medical equipment assigned to the patient. Those are all included in the patient zone. Everything outside of that is then regarded as the healthcare zone. So it's all items and equipment found in other areas such as the nurse's station, the sluice room, the linen room, and other clinical areas. So the patient zone is that area that is specifically assigned to the patient, and the surrounding, the equipment and the furniture that is assigned to that patient. If we look at the 5 moments of hand hygiene, I just said that whenever we enter the patient zone, we need to perform hand hygiene according to the 5 moments. And those moments are before patient contact, before an aseptic procedure, after body fluid exposure, after contact with the patient, and then after contact with the patient's surroundings. I specifically want to talk about gloves because this is a very important part for me, especially in the operating theatre. Sometimes we wear gloves and then we think that we are protected. Yes, perhaps we as a healthcare workers are protected, but potentially we can transmit pathogens to the patient or to the environment. So it's very important that gloves are used appropriately. So when should we use gloves? First of all, when there is a risk of blood and body fluid exposure, then as part of transmission-based precautions, and then during an aseptic procedure, we will use sterile gloves. Then we need to remove gloves immediately after completion of a procedure. Do not touch anything in the environment with gloved hands. We often see that healthcare workers, they will touch the patient, they will perform what they need to perform, but then they do not remove their hands. So then they will continue to write in the clinical notes, touch their pen, touch their notes, the overbed table or the writing surface, potentially contaminating those areas. Always perform hand hygiene before donning and after removal of gloves. Gloves must be changed between patient care opportunities as well as between patients. A new thing that we've started to observe now during COVID is that healthcare workers, first of all, double glove, and we see that they use alcohol hand rub on gloves. That should never happen. You should never decontaminate your gloves because potentially the alcohol can make microscopic holes in the gloves that can then puncture the gloves and compromise the integrity of the gloves. Also, with time, the gloves become sticky, which is also problematic. There was a study that was published by Giro and his colleagues. They did it in 5 wards, 3 intensive care units and then 2 medical wards in a French university hospital. They looked at staff patient and staff environment contacts were observed in 120 healthcare workers caring for patients colonized or infected with pathogenic bacteria. Hand hygiene was not undertaken due to improper gloving in 64.4%. So in 64.4% of opportunities, hand hygiene were not performed. Possible microbial transmission might have occurred in 18.3% of these contacts because used gloves were not removed before performing care activities that necessitated strict aseptic precautions. Failure to change gloves or remove contaminated gloves was a major component in the poor compliance with hand hygiene and carried a high risk of microbial transmission. Improving hand hygiene compliance will require changing healthcare workers' behavior towards glove use. And that was the conclusion of these French scientists. And we see that in various other parts of the world as well. I recently listened to a webinar that was presented by the English Society of Infection Control, and they saw in the one unit, in the one COVID unit, they saw a huge increase in the CLAPSI, and they contributed, one of the reasons was the inappropriate glove use, and they stopped wearing gloves, and they saw an improvement in their CLAPSI rates. The misuse of the scrub basins and the impact on hand hygiene. So Xana referred to this last or in the previous webinar. She specifically spoke about the misuse of the scrub basins. And that is actually an extremely important point, because we often see that scrub basins and hand wash basins are being used to wash and clean instruments in, or even to discard body fluids in, and that's extremely dangerous because you get biofilm formation in the pipes, which can lead to various kinds of problems, such as outbreaks of multi-drug resistant organisms, and there are documented proof, or there are a number of studies published on the danger of, or the impact of biofilm formation in the hand wash basins, and then also in the down pipes. So we should never wash any instrument in a hand wash basin or in a scrub basin. Never discard body fluids in basins, and there's a risk of colonization, biofilm formation, and transmission of MDROs, which is then contaminating the hands and the clothes of healthcare workers. In this study, published a while ago by Hotta and colleagues, they looked at Pseudomonas, or the impact of Pseudomonas outbreaks that they had in a unit. And they found that biofilm formation was one of the reasons why the environment had been contaminated. And they found, and that's an old study that was already done in 2004. It was done between 2004 and 2006. So they had a look at a Pseudomonas outbreak in an intensive care unit of a tertiary hospital. And what they found was all phenotypically similar isolates were examined for genetic relatedness by means of pulse field gel electrophoresis, and clinical characteristics of the affected patients were collected, and a detailed epidemiological and environmental investigation of potential sources was carried out. And 17 of the infected patients died within 3 months. For 12 of these patients were infection where the outbreak contributed were directly related to the Pseudomonas that they cultured in these hand wash basins and were similar to the other patients. And the source of the outbreak was traced back to the hand hygiene zinc drains where biofilms containing viable organisms were found. So they could directly link it back to the hand wash basins, and then the splashing was up to 1 meter. They could find with fluorescent markers and ink. They found that the splashing, they could find it 1 meter away from the hand wash basin. So similar studies were done by Hopman and also De Geiter, where they looked at the role of the contaminated hand wash basins. And the new tendency is actually not to use clinical hand wash basin or hand wash basins in clinical areas. Then the other important thing that we need to, or that we want to talk about today, is the environmental cleaning. And when I wrote this sentence, I actually thought, I'm not too sure why we need all this evidence to demonstrate how important environmental cleaning is, but there is increasing evidence that environmental surfaces in the OR, including anesthesia work areas, can harbor pathogens that can cause HIIs. Equipment used routinely in the OR can become contaminated with pathogens during surgical procedures and can pose a risk for pathogen transmission and subsequent infection without proper cleaning and disinfection between procedures. It is essential to properly clean and disinfect environmental surfaces after each patient. So we now actually have studies that prove that it is important to clean between cases. It is not enough to only clean at the end of the day or the beginning of the day. We have to clean in between patients. In this article published by AORN, the American Operating Room Society, they describe the reasons for environmental cleaning very well, and also the risk of pathogen contamination of the environment. Xana spoke the previous time, she spoke about the risk of the environment in the transmission, and she specifically referred to when we need to clean, in the morning a damp dust, then between cases, and then at the end of the list that we need to push out. And that means that we push out everything and clean all surfaces. It is important that we clean and disinfect. We cannot just disinfect. We have to first clean to get rid of the bioburden. This is just a very nice infographic that I got in that article that I just referred to, which indicates which areas need enhanced cleaning, which areas like the floor only and the walls. Those are lower risk areas, so they only need to be cleaned when they are soiled, but then all the other areas need to be cleaned after each and every patient, and also which need enhanced cleaning. Then, if we further look at the what factors are important when we talk about environmental cleaning, I do believe it's extremely important that we have clear role clarification, that the cleaning services know what they are responsible for, and that our nurses know what they are responsible for. So it doesn't help that we think that the cleaners should clean the equipment, but we didn't communicate it with them. So it is extremely important that we have clear role clarification and that each and everybody knows what they are responsible for. It's also important that if we expect of people to clean difficult equipment or sensitive to expensive equipment, that they've been trained how to do that. We cannot just give them an aesthetic machine and tell them to clean it, but we haven't told them how to do it. Communication is essential. It is important to clean before we disinfect. I alluded to it in the previous slide. So it is important that we first have to remove the bioburden, the blood and the dirt and the organic material before we can disinfect. We cannot make dirt safe. This is something that Prof. Mehta always says, that disinfectants do not make dirt safe. We first have to remove the dirt. Then we need to measure compliance to environmental cleaning. It's very helpful to have a checklist that you use to make sure that you covered all the areas. And a fluorescent marker, ultraviolet power and ultraviolet light is very helpful to see which areas you possibly missed. Then feedback. We need to provide feedback after we've cleaned. There must be some kind of accountability. If I didn't do my job, there must be consequences. And then the most important, I think, is acknowledgement. If somebody did something good, we have to acknowledge that they did a good job. If we talk about UV lights, that is something that is extremely helpful to monitor environmental cleaning. So a fluorescent marker and a UV light. You mark the areas, and then after it was cleaned, you shine the UV light to see which areas had been missed. This is a study that was published by Sitzler and colleagues, and here they look at 3 different things to enhance cleaning in rooms with patients with C. diff. And what they found was that the fluorescent marker intervention improved the thoroughness of cleaning of high-touch surfaces from 47% to 81%. So it's very helpful if you can have that visual tool. If we look at methods to assess environmental cleaning, there are different ways that you can do it. So first of all, there's visual inspection, where you use the checklist and you assess the areas to assure that you've cleaned all the areas. So you will tick those areas that have been cleaned. Then there's the marking surfaces with a fluorescent dye and or powder or a marker, and you then use the UV light to see whether the areas had been cleaned. I alluded to that in the previous slide. And then you can culture surfaces, which is very expensive and not really recommended. And then there's ATP bioluminescence assay to measure cleaning. So in this webinar that I attended by Professor Andreas Vos of the Netherlands, the different methods to assess environmental cleaning was compared. And he found that, visual assessment was actually the least effective. He said that visual assessment of hygiene does not correlate with microbial contamination and is a misleading measure of cleanliness. So that is not at all recommended. It's very difficult to just look at a place and to see whether it's clean or not, or just use a checklist. So the two methods you will see here on this table, that ATP and fluorescent light actually compared very well. ATP bioluminescence detects the amount of ATP, which is an indirect measure of the amount of organic or food residue on a surface that has the potential to support microbial growth and also microbial biomass. In simple terms, it measures the dirt or filth on a surface, indicating the need for cleaning and sanitizing. So it's a very helpful way to measure whether an area is clean or not. So those two, ATP and then the fluorescent marker, were the best to compare or to evaluate cleaning. And then the last slide that I want to end with is that it's all good and well to look at all these aspects, but it is extremely important that we always use a multimodal approach. I cannot only focus on hand hygiene and I forget about all the others, because then I will not have the necessary outcome or the necessary result. It is important that we do all these things collectively to ensure that we address our infection prevention and control concerns. We need to focus on hand hygiene, environmental cleaning. We need to do surveillance where we are in terms of our HIRs. How many surgical site infections do we have? What is causing the surgical site infection? We have to look at the aseptic technique, transmission and transmission-based precautions, standard and transmission-based precautions, education and training, antimicrobial stewardship, and then we need to look at behavioral change and continuous improvement. And in the theatre environment, that then translates to the other things that I spoke about is the ventilation, the temperature, the relative humidity is then included in this. So thank you very much. Just one last thing is I reference a few guidelines here. Two of these guidelines are South African guidelines, and I think they are very helpful when we want to look at infection control aspects or specifically related to cleaning or hand hygiene. The one is the National Infection Prevention and Control Strategic Framework, and that is then supported by the implementation guideline. And then another document that was published by the CDC is Environmental Cleaning in Healthcare Facilities, a best practice manual, which is extremely helpful. All right, that's it from my side. Thank you very much.
Briette, thank you very much. If anybody has any questions, if you feel like typing in the chat box, you can with pleasure, or raise your hand. But I think one of the important things for me is that, you know, a theatre matron, a theatre sister, we always talk that we're in charge of our theatre, and we remain responsible for everything that happens in that theatre. At the end of the day, we're there to protect the patient. So making sure that the environment is cleaned is part of that. You know, as student nurses, we started by learning to push out at the end of the list. It's a critical feature and a very basic but very important concept, I honestly believe. So that's why the first time I heard you present this, I was intrigued, because I think we don't always know what we need to know, or know to the right level of what it is that we need to know. So thank you very much. Nanette, anything that popped up for you?
I think the most important thing that is for me is we can never underestimate cleaning. Whether it's cleaning your hands, whether it's cleaning the environment, whether it's keeping your HVACs clean, cleaning, just the action of cleaning is so important and often overlooked. That's me.
Agreed, and I must say, Briette, that all the published papers say something similar about trying to determine whether whether an instrument is clean. The visual, in just standard visual naked eye inspection, is really the least reliable. And that's why these days there's a focus towards some form of scientific measure, so using residual protein, for example, to test whether something is clean or dirty, and enhanced visual inspection, so trying to find ways to see better whether the instrument isn't clean or not clean, and that's, of course, using magnification, lighted magnification, etc. These days they're getting onto fancy things called ball scopes that you can put down instruments to have a look and see how clean they are or aren't. It would be quite interesting if we put a ball scope through some of the corners of an operating table. I think we might be a bit scared. Anyway, thank you very much, Briette. That was really, really awesome. We really appreciate that. We will have our next webinar next week again, and as normal, I will send you the link to the test. I haven't sorted out all the certificates from our last webinar, but I'll make sure everybody that requires a certificate of attendance, remember you do need to fill in the short survey and the few test questions, so we've got evidence of your learning. Thank you so much, Briette. Thank you, everybody else, and have an awesome day.